Pathology of Fear is a medical documentary series presenting clinically documented neurologic and pathological mechanisms for educational analysis.
The patient is seated in a neurology clinic exam room, hands resting loosely on his thighs. He is in his late 30s. He is employed full-time. His medical history is unremarkable. He is not here for pain, weakness, or memory loss. He is here because something feels off. He reports increasing difficulty controlling small automatic movements. Fingers twitch when he is tired. His foot taps without intention. At work, colleagues have commented that he seems restless or distracted. He has noticed irritability he cannot fully explain. Minor frustrations provoke disproportionate reactions. He recognizes these changes and finds them unsettling. There is no confusion. Language is intact. He follows conversation easily. He recalls recent events without difficulty. He understands why he is here and articulates his concerns clearly. On examination, vital signs are normal. Cranial nerves are intact. Eye movements are full. Speech is fluent. Strength testing shows full power in all extremities. Muscle tone is normal. There is no rigidity, no tremor at rest. Sensory testing is normal. When asked to hold his hands outstretched, subtle, irregular finger movements appear, brief, non-rhythmic, difficult to characterize. They disappear when attention is redirected. Gait is stable, though slightly fidgety. Tandem walking is intact. Reflexes are symmetric. Nothing on the exam suggests an acute neurological disorder. The neurological findings are mild, inconsistent, and easily dismissed. On paper, the exam is reassuring. Yet the patient's concern remains unresolved. The symptoms did not begin abruptly. There was no injury, no infection, no clear starting point. The earliest changes were behavioral: increased impatience, reduced tolerance for delay, difficulty suppressing impulsive remarks. At the time, these were attributed to stress. Motor changes followed quietly. Small movements escaped conscious control. Fidgeting became constant. Tasks requiring fine motor precision felt less reliable. None of these changes interfered with basic function. They accumulated gradually, blending into daily life. Primary care evaluation was unrevealing. Routine blood work was normal. Sleep hygiene was discussed. Stress management was recommended. Anxiety was considered. Depression screening was negative. The patient was reassured. What delayed escalation was not absence of symptoms, but their nature. There was no dramatic deficit, no loss of strength, no memory impairment, no sensory loss. The nervous system did not appear broken. It appeared inefficient. When family history was discussed, the patient hesitated. He mentioned that his father died in his early 50s after years of behavioral change and movement problems. The diagnosis was never clearly explained. It was described vaguely as a neurological condition. Genetic testing was never discussed openly within the family. This detail was not volunteered initially. It emerged late in the conversation, framed with uncertainty and discomfort. The patient does not know if it matters. In early Huntington's disease, this is common. The disease does not announce itself with paralysis or dementia. It begins by eroding control rather than capacity. The brain can still think, remember, and perceive. What it cannot do reliably is suppress unwanted movement, regulate impulse, or maintain behavioral inhibition. These changes are subtle enough to be misclassified. Early Huntington's disease is frequently interpreted as a psychiatric disorder. Irritability, impulsivity, mood instability, and restlessness dominate the presentation. Cognitive testing may be normal. Insight is preserved. The patient recognizes something is wrong but cannot localize it. Motor signs are present, but they are not yet dramatic. Movements are excessive rather than absent. They are irregular rather than rhythmic. They worsen under stress and fatigue. They disappear briefly with concentration. This variability reinforces non-neurological explanations. Neuroimaging at this stage may be normal or show only subtle changes. There is no focal lesion, no stroke, no tumor. Laboratory testing does not reveal inflammatory or metabolic disease. Without clear structural markers, the diagnosis remains elusive. The age of the patient works against recognition. Neurodegenerative disease is not expected in the late 30s. When it occurs, it is expected to affect memory first. Huntington's disease violates this expectation. It targets circuits of control rather than storage. What is being lost is not intelligence, it is inhibition. The basal ganglia, particularly the striatum, regulate the balance between initiating movement and suppressing unwanted motor output. They also modulate behavior, impulse control, and emotional regulation. In Huntington's disease, these systems are compromised early, long before widespread neuronal loss is evident. The patient can still plan, he can still reason, he can still remember. What he cannot do consistently is stop. The visit ends without resolution. Monitoring is recommended, stress reduction is advised, follow-up is planned. The patient leaves with reassurance that nothing serious has been identified. The disease, however, is already active. Huntington's disease does not begin at the moment of diagnosis. It begins decades earlier, encoded in DNA, silent and unavoidable. By the time subtle loss of control reaches clinical attention, the biological process has been unfolding for years. What appears as restlessness is not anxiety. What appears as irritability is not personality change. What appears as poor impulse control is not moral failure. It is the earliest manifestation of a neurodegenerative process driven by a single genetic expansion, slowly dismantling the systems that restrain movement, behavior, and thought. This is not a disease of forgetting. It is a disease of losing control. The delay between symptom onset and diagnosis in Huntington's disease is not caused by lack of medical knowledge. The gene has been identified for decades. The inheritance pattern is well described. The clinical syndrome is documented. And yet, the disease is still recognized late. The reason is not scientific uncertainty. It is human behavior. Huntington's disease is autosomal dominant. One copy of the expanded gene is sufficient to cause the disorder. There is no carrier state. There is no partial protection. If the mutation is present, the disease will develop. This clarity does not produce early diagnosis. It produces avoidance. Families affected by Huntington's disease often learn about the diagnosis only after symptoms become undeniable. The knowledge that a single genetic test can confirm an inescapable outcome creates a powerful incentive not to look. Testing is delayed or refused. Family history is minimized, fragmented, or described in vague terms. Details are lost intentionally. In clinical encounters, this avoidance translates into incomplete histories. Parents are described as having had mental health problems or movement issues without a name attached. Early deaths are attributed to accidents or unrelated illness. The inheritance pattern is obscured by silence rather than ignorance. Patients themselves may not know the diagnosis that affected previous generations. In many families, Huntington's disease is never named aloud. The fear of inevitability suppresses discussion. This silence delays recognition. Early Huntington's disease does not resemble the expected image of neurodegeneration. Memory is preserved. Language is intact. Intelligence appears unchanged. What deteriorates first is regulation of movement, impulse, and emotion. These changes map more closely onto psychiatric diagnoses than neurological ones. Irritability, emotional lability, impulsivity, depression, and anxiety dominate early presentation. These symptoms fluctuate. They worsen under stress. They respond inconsistently to treatment. This variability reinforces psychiatric framing. Movement abnormalities are present early, but they are subtle. Small, irregular movements are dismissed as nervous habits or medication side effects. Restlessness is interpreted as anxiety. Poor inhibition is attributed to personality or stress. The motor system is active, not failing, and this contradicts expectations of neurological disease. When neurological consultation occurs, examination findings may still be equivocal. Chorea is mild or intermittent. Gait remains functional. Reflexes are normal. strength is preserved. Imaging may not yet show significant atrophy. There is no acute lesion to anchor diagnosis. Age compounds the delay. Huntington's disease often presents in the fourth decade of life. At this age, psychiatric explanations are statistically more likely than neurodegeneration. Clinicians follow probability. Without a clear family history or unmistakable motor signs, Huntington's disease remains low on the differential. Genetic testing, which could clarify the diagnosis immediately, is not pursued lightly. A positive test confirms not only the diagnosis, but the inevitability of progression. There is no disease-modifying cure. This reality weighs heavily on patients and clinicians alike. Testing carries consequences beyond medicine. It affects employment, insurance, family planning, and psychological well-being. For some, not knowing feels safer than certainty. This hesitation delays confirmation even when suspicion arises. Meanwhile, the disease progresses. The concept of anticipation further complicates recognition. In Huntington's disease, the number of KAG repeats can increase when passed to the next generation, particularly through paternal inheritance. This expansion leads to earlier onset and more severe disease. As a result, the age of onset may differ dramatically between parent and child. A parent who developed symptoms in their 50s may have a child who becomes symptomatic in their 30s. This temporal shift obscures the connection between generations. The disease appears different, even though the mechanism is the same. By the time motor symptoms become unmistakable, the opportunity for early intervention has passed. Neuronal loss has already begun. The disease is no longer subtle. It is visible, progressive, and irreversible. The diagnostic delay in Huntington's disease is therefore not a failure of genetics. It is a collision between biological inevitability and psychological resistance. The disease is known. The mechanism is known. The outcome is known. What is avoided is the moment when knowledge becomes personal. By the time that moment arrives, the disease has already been active for years, dismantling the circuits that control movement, behavior, and restraint. Huntington's disease does not hide because it is rare. It hides because it is unavoidable. Huntington's disease is not triggered by injury, infection, or exposure. It is present from birth, encoded within a single gene on chromosome 4. The disease does not emerge because something new appears later in life. It emerges because something that has always been there finally becomes toxic. That gene is HTT, which encodes the Huntingtin protein. Within the HTT gene lies a sequence of 3 DNA bases, cytosine, adenine, and guanine, repeated multiple times in a row. This is known as a KAG trinucleotide repeat. In unaffected individuals, the number of repeats falls within a stable range. The gene functions normally. The protein it produces folds correctly and performs its roles without damaging the cell. In Huntington's disease, this repeat sequence is expanded beyond a critical threshold. The number of KAG repeats determines whether the disease will occur, and to a degree, when symptoms will begin. Individuals with fewer than approximately 26 repeats do not develop Huntington's disease. Those with intermediate repeat lengths may not develop symptoms themselves, but carry unstable alleles capable of expansion in the next generation. Once the repeat count exceeds the pathogenic range, the disease becomes inevitable. There is no carrier state. If the pathogenic expansion is present, Huntington's disease will develop. The only uncertainty is timing. This inevitability is central to the fear associated with the disease. Unlike many genetic conditions that increase risk, Huntington's disease guarantees outcome. The mutation does not create vulnerability, it creates certainty. Despite this, the disease does not manifest at birth or in childhood. The Huntingtin protein is produced continuously throughout life, even in individuals with expanded repeats. For decades, neurons tolerate its presence. The nervous system compensates. Cellular defenses delay toxicity. This delay creates the illusion that the gene is dormant. It is not. The expanded KAG repeat produces a Huntingtin protein with an abnormally long polyglutamine tract. This altered structure changes how the protein folds and interacts with other cellular components. The protein is not missing. It is not reduced. It is present in excess of normal length, carrying a toxic gain of function. This distinction matters. Huntington's disease is not caused by absence of Huntingtin. The normal protein plays important roles in cellular transport, transcriptional regulation, and neuronal survival. Removing it entirely is harmful. The disease arises because the expanded protein acquires properties that neurons cannot tolerate indefinitely. The length of the CAG repeat influences the behavior of the protein. Longer repeats increase instability, misfolding, and aggregation. They also correlate with earlier onset. Individuals with very long expansions may develop symptoms in adolescence or childhood. Those with shorter pathogenic expansions may not show symptoms until middle adulthood. This relationship is not linear, but it is consistent enough to shape prognosis. The phenomenon of anticipation emerges from this instability. When the HTT gene is passed from parent to child, the KG repeat can expand further, particularly during spermatogenesis. As a result, children may inherit a longer repeat than their affected parent. This expansion leads to earlier onset and more aggressive disease in successive generations. Anticipation explains why Huntington's disease can appear to change character within a family. A parent may develop symptoms in their 50s, while a child becomes symptomatic in their 30s. The disease is the same. The genetic expansion is larger. This intergenerational acceleration contributes to diagnostic confusion. The connection between generations may not be immediately recognized. The disease appears to shift rather than repeat. The Huntingtin gene is expressed in nearly every cell of the body, yet Huntington's disease selectively targets specific neuronal populations. This selectivity is not explained by where the gene is expressed, but by how different cells tolerate the toxic protein. Neurons, particularly those involved in movement and behavioral regulation, are uniquely vulnerable to disruptions in protein handling, energy metabolism, and transcriptional control. The expanded Huntingtin protein interferes with all three. Importantly, the presence of the expanded gene does not immediately destroy neurons. Cellular systems responsible for protein quality control, chaperone proteins, proteasomes, autophagy pathways, work continuously to manage misfolded proteins. For years, they succeed. Over time, however, the burden accumulates. Misfolded Huntingtin fragments aggregate. Clearance mechanisms become overwhelmed. The protein begins to interfere with normal cellular processes. Transcription of critical genes is disrupted. Mitochondrial function declines. Axonal transport becomes inefficient. This slow accumulation explains why Huntington's disease unfolds over decades rather than days or months. The disease is not triggered, it is revealed. From the moment of conception, the expanded gene is present. The nervous system develops around it. For years, function appears normal. The damage is molecular, not structural. When symptoms finally emerge, the disease has already crossed a biological threshold. The accumulation of toxic protein has begun to compromise the neurons most sensitive to its effects. The gene did not suddenly become active. The nervous system simply ran out of ways to compensate. Huntington's disease is therefore not a disorder of aging. It is not the result of wear and tear. It is the delayed consequence of a genetic expansion that guarantees eventual failure of specific neural systems. The Huntingtin gene does not change over time. What changes is the cell's ability to survive its presence. The damage in Huntington's disease does not originate from the absence of a necessary protein. It originates from the presence of one that should not exist in its expanded form. The mutant Huntingtin protein does not fail to perform a function. It acquires new, destructive properties. This is a toxic gain of function. The expanded polyglutamine tract alters how the Huntingtin protein folds. Normal Huntingtin adopts conformations that are compatible with cellular machinery. Mutant Huntingtin is unstable. It misfolds easily. Portions of the protein resist degradation and begin to interact abnormally with other proteins inside the cell. These abnormal interactions are not random. Mutant Huntingtin binds to transcription factors, disrupts protein trafficking, interferes with mitochondrial enzymes, and impairs the systems responsible for protein clearance. It inserts itself into processes that neurons depend on for survival, not by replacing normal components, but by obstructing them. One of the earliest consequences is protein aggregation. Misfolded Huntingtin fragments accumulate and clump together, forming oligomers and inclusions within the cytoplasm and nucleus of neurons. These aggregates are not inert. They sequester other proteins, pulling essential cellular components into non-functional complexes. The cell loses access to proteins it still possesses. This creates a paradox. The neuron contains the necessary machinery, but it cannot use it. The nucleus is particularly affected. Mutant Huntingtin interferes with transcriptional regulation by binding to transcription factors and chromatin-modifying proteins. Genes required for neuronal survival, synaptic maintenance, and energy metabolism are downregulated. Stress response genes are activated chronically. The balance shifts away from maintenance and toward survival under threat. Over time, this transcriptional dysregulation becomes self-reinforcing. The neuron produces fewer protective proteins and more stress-related signals. Its capacity to manage damage declines. Protein clearance systems are also compromised. Neurons rely on the ubiquitin proteasome system and autophagy to remove misfolded proteins. Mutant Huntingtin overwhelms these pathways. The proteasome becomes clogged. Autophagic vesicles accumulate without completing degradation. The cell expends energy attempting to clear a burden it cannot eliminate. This failure is not immediate. For years, neurons compensate. Clearance pathways upregulate. Chaperone proteins increase expression. Cellular stress responses activate. These adaptations delay collapse but come at a cost. Energy consumption rises. Normal cellular operations are deprioritized. Mitochondrial function begins to decline. Mutant Huntingtin interferes with mitochondrial dynamics, transport, and enzyme activity. Mitochondria become less efficient at generating ATP. Reactive oxygen species increase. Calcium handling becomes unstable. Neurons, which rely on continuous energy supply, begin operating closer to metabolic failure. Axonal transport is disrupted as well. Neurons depend on long-distance transport of proteins, vesicles, and mitochondria along microtubules. Mutant Huntingtin interferes with motor proteins responsible for this transport. Synaptic terminals receive fewer resources. Distal regions of neurons become metabolically vulnerable. Synaptic maintenance falters. These disruptions are subtle at first. Synapses function less reliably. Plasticity declines. The neuron still fires, but communication becomes inefficient. This inefficiency precedes cell death by years. Importantly, mutant Huntingtin is expressed in nearly all neurons, yet Huntington's disease does not destroy all neurons equally. This selective vulnerability reflects differences in how neuronal populations tolerate protein misfolding, energy stress, and transcriptional disruption. Neurons that rely heavily on precise inhibitory control and high metabolic throughput are affected first. The striatum, particularly medium spiny neurons, becomes the earliest and most severely damaged region. Other regions follow later as compensatory capacity is exhausted. The toxic effects of mutant Huntingtin do not require inflammation, infection, or immune activation. The disease progresses in the absence of external insult. It is driven by intracellular accumulation of a protein that the cell cannot remove. This explains why Huntington's disease unfolds slowly, but relentlessly. The protein is present from birth. Aggregation begins early at a molecular level. Clearance mechanisms delay damage. Eventually, the burden exceeds capacity. Neurons transition from compensation to failure. Importantly, aggregates themselves are not the only source of toxicity. Smaller, soluble oligomers of mutant Huntingtin are particularly damaging. These species interact more readily with cellular machinery, disrupting function without forming visible inclusions. This explains why pathology precedes obvious histological changes. By the time aggregates are prominent, damage has already occurred. The presence of mutant Huntingtin also interferes with synaptic signaling. glutamatergic input becomes dysregulated. Dopaminergic modulation is altered. Excitatory-inhibitory balance shifts. Neurons are exposed to excitotoxic stress, further accelerating injury. Despite this, neurons do not die immediately. They persist in a compromised state, functioning below capacity. This produces early symptoms that are subtle, variable, and easily misclassified. Behavioral disinhibition, restlessness, and mild motor irregularities emerge long before widespread neuronal loss is evident. This prolonged pre-death phase is central to Huntington's disease. The disease is not marked by sudden neuronal destruction. It is marked by prolonged dysfunction, driven by a protein that cannot be cleared and cannot be silenced. Once the cumulative effects of misfolding, aggregation, transcriptional disruption, and metabolic stress reach a threshold, neurons begin to die. At that point, the disease enters a new phase, one defined by structural loss rather than functional instability. But that transition is still ahead. At this stage, the damage remains largely invisible on routine imaging. The brain appears intact. The patient remains cognitively present. What has changed is not structure, but tolerance. The nervous system is carrying a burden it was never designed to bear, and it cannot do so indefinitely. Huntington's disease does not damage the brain uniformly. Although the mutant Huntingtin protein is expressed throughout the nervous system, neuronal loss follows a precise anatomical pattern. The earliest and most severe degeneration occurs within the striatum, a core component of the basal ganglia. This selectivity is not accidental. The striatum integrates signals from across the cerebral cortex and modulates motor output, behavioral inhibition, and decision-making. It functions as a gatekeeper, determining which motor and cognitive programs are allowed to proceed and which are suppressed. This role requires continuous, precisely regulated inhibitory control. The neurons responsible for this function are medium spiny neurons. Medium spiny neurons are inhibitory projection neurons that constitute the majority of striatal cells. They receive dense glutamatergic input from the cortex and dopaminergic modulation from the midbrain. Their job is not to generate movement directly, but to regulate the flow of activity through basal ganglia circuits. This regulation is metabolically expensive. Medium spiny neurons maintain a hyperpolarized resting state and require coordinated synaptic input to fire. They rely heavily on mitochondrial energy production, calcium buffering, and intact transcriptional regulation to maintain stability. These same requirements make them particularly vulnerable to the toxic effects of mutant Huntingtin. The expanded Huntingtin protein interferes with each of these systems simultaneously. First, transcriptional dysregulation disproportionately affects medium spiny neurons. These cells depend on tightly controlled expression of genes involved in synaptic maintenance, energy metabolism, and calcium handling. Mutant Huntingtin disrupts transcription factors critical to these processes, reducing the production of protective proteins. Second, mitochondrial dysfunction is especially damaging in the striatum. Medium spiny neurons have limited energetic reserve. When mutant Huntingtin impairs mitochondrial enzymes and transport, ATP production falls. These neurons cannot compensate effectively, leaving them vulnerable to metabolic stress. Third, excitotoxic vulnerability accelerates degeneration. Cortical glutamatergic input is essential for striatal function, but it is also dangerous when regulation fails. Mutant Huntingtin alters glutamate receptor expression and impairs astrocytic glutamate clearance. As a result, medium spiny neurons are exposed to excessive excitatory signaling. Calcium influx increases. Oxidative stress rises. Cellular injury accelerates. Dopaminergic modulation further complicates this vulnerability. Dopamine normally fine-tunes striatal output, balancing facilitation and inhibition. In Huntington's disease, dopamine signaling becomes dysregulated. Early in the disease, dopaminergic activity may be relatively preserved or even excessive relative to inhibitory control. This imbalance contributes to hyperkinetic movement patterns such as chorea. As medium spiny neurons degenerate, inhibitory output from the striatum declines. The basal ganglia lose their capacity to suppress unwanted movement and behavior. Motor programs that should be filtered out are released. This is why Huntington's disease produces excess movement, not paralysis, early on. The degeneration within the striatum follows a predictable sequence. Neurons involved in the indirect pathway, which suppress movement, are lost first. This selective loss disinhibits motor circuits, producing involuntary, irregular movements. Later, neurons in the direct pathway are affected, leading to rigidity, bradykinesia, and loss of voluntary motor control. This transition explains the evolution of symptoms over time. Early Huntington's disease is characterized by chorea, random, flowing movements that appear purposeless. As degeneration progresses, movement becomes slower and more rigid. The system shifts from uncontrolled activation to global failure. The striatum's role in behavior and cognition explains parallel changes outside the motor system. Medium spiny neurons also regulate fronto-striatal circuits involved in executive function, impulse control, and emotional regulation. As these neurons fail, the brain loses its ability to suppress inappropriate thoughts, actions, and emotional responses. The patient knows what should be done. The circuitry that enforces restraint is gone. Importantly, the cortex itself remains structurally intact early in the disease. Memory, language, and perception are preserved because cortical neurons are initially spared. The dysfunction arises from loss of striatal modulation, not cortical destruction. This creates a distinctive clinical dissociation. The mind remains capable of thought and awareness. The machinery that regulates output fails. The patient experiences themselves acting without full control, responding emotionally without proportional restraint, and moving without intention. This is not loss of intelligence. It is loss of gating. As medium spiny neurons continue to degenerate, secondary changes occur. White matter tracts connecting the striatum to cortex and thalamus deteriorate due to loss of trophic support. Cortical regions begin to show metabolic decline. The disease spreads from a focal subcortical pathology into a distributed network disorder. But the striatum remains the epicenter. The selective vulnerability of medium spiny neurons defines Huntington's disease. It explains why movement and behavior are affected before memory. It explains why excess movement appears before weakness. It explains why early symptoms feel psychiatric rather than neurological. The disease does not dismantle the brain globally at first. It removes a specific population of neurons whose role is to suppress, regulate, and restrain. When those neurons are lost, control itself is lost. This vulnerability is not a coincidence of anatomy. It is the intersection of mutant protein toxicity, metabolic demand, excitatory stress, and inhibitory function concentrated in a single neural population. The striatum cannot tolerate the burden imposed by mutant Huntingtin indefinitely. Once medium spiny neurons begin to die, the trajectory of Huntington's disease is set. What follows is not random decline, it is circuit disintegration. The motor failure of Huntington's disease does not arise from weakness, paralysis, or loss of motor intent. It arises from collapse of the circuits that decide which movements should not occur. This distinction is essential. Voluntary movement is not produced by the motor cortex alone. It is shaped, filtered, and regulated by the basal ganglia before execution. These structures determine which motor programs are permitted and which are suppressed. In Huntington's disease, this filtering system fails. The result is movement without restraint. Under normal conditions, the basal ganglia operate through two major pathways: the direct pathway, which facilitates desired movement, and the indirect pathway, which suppresses unwanted movement. Medium spiny neurons populate both pathways and maintain balance between activation and inhibition. Huntington's disease disrupts this balance asymmetrically. The earliest neuronal loss occurs in medium spiny neurons of the indirect pathway. These neurons are responsible for suppressing excessive or inappropriate motor output. When they degenerate, the inhibitory brake on movement is released. Motor programs that should remain silent are expressed. This produces chorea, the defining motor feature of early Huntington's disease. Chorea consists of irregular, non-rhythmic, flowing movements that appear purposeless and unpredictable. They may involve the face, limbs, trunk, or neck. Movements blend into voluntary action, making them difficult to suppress or consciously control. They worsen with stress, fatigue, and emotional arousal. Chorea is not tremor. It is not spasm. It is not seizure activity. It is the expression of motor commands that were never meant to be executed. Because motor strength remains intact, the patient can still walk, grasp objects, and perform tasks. The problem is not capacity, it is regulation. The nervous system generates too many motor signals, too freely. Early in the disease, patients may attempt to disguise chorea by incorporating movements into purposeful action. This masking delays recognition. Observers may interpret movements as restlessness or nervous habits, rather than neurological disease. As indirect pathway degeneration progresses, motor inhibition deteriorates further. Movements become more frequent and more intrusive. Posture becomes unstable. Gait becomes unpredictable. Fine motor control degrades. Importantly, voluntary movement is still possible. The patient can initiate action. They can plan movement. They can execute tasks. What they cannot do is prevent interference from unwanted motor output. The body does not remain still when stillness is required. Over time, degeneration extends beyond the indirect pathway. As disease advances, medium spiny neurons of the direct pathway are also lost. These neurons normally facilitate intentional movement. Their loss produces a second phase of motor decline. The disease transitions from hyperkinesia to hypokinesia. Chorea diminishes, not because control returns, but because the system can no longer generate coordinated movement efficiently. Rigidity increases. Bradykinesia emerges. Voluntary movement becomes slow and effortful. This transition is often misunderstood. Observers may believe the disease is improving because excessive movements decrease. In reality, the motor system is collapsing more completely. Both facilitation and inhibition are failing. The basal ganglia no longer regulate movement at all. This produces a paradoxical motor state. Movements are fewer but less effective. Postural instability worsens. Balance deteriorates. Falls increase. Muscle tone becomes abnormal. The cerebellum attempts to compensate, but compensation is limited. Cerebellar correction depends on accurate input from basal ganglia modulated circuits. When those inputs are degraded, coordination cannot be restored. Speech is affected as these circuits fail. Dysarthria develops. Speech becomes irregular in rhythm and articulation. Volume control deteriorates. These changes reflect motor timing failure rather than language impairment. Swallowing becomes unsafe as coordinated muscle sequencing degrades. Aspiration risk rises. Nutritional status declines. These complications accelerate functional decline. Throughout this progression, sensory systems remain largely intact. The patient feels movement errors. They recognize instability. The problem is not feedback, it is execution. This preserved awareness is central to the experience of Huntington's disease. The individual feels their body move against their will. They attempt to suppress movements and fail. They experience loss of control without loss of consciousness or understanding. This is not a peripheral motor disorder, it is central disinhibition. As striatal degeneration spreads, downstream nuclei within the basal ganglia are also affected. Thalamic output becomes dysregulated. Motor cortex receives abnormal signals. Corticospinal pathways remain intact, but are poorly governed. The motor cortex executes what it receives. Over time, white matter tracts connecting basal ganglia, thalamus, and cortex deteriorate due to loss of trophic support. Motor dysfunction becomes less variable and more fixed. Compensation fails. The progression from chorea to rigidity reflects the sequence of circuit failure, not disease resolution. It marks the transition from selective inhibitory loss to global basal ganglia collapse. This pattern distinguishes Huntington's disease from other movement disorders. Parkinson's disease begins with loss of movement initiation. Huntington's disease begins with loss of movement suppression. The difference lies in which basal ganglia pathways fail first. In Huntington's disease, the nervous system does not forget how to move. It forgets how to stop. By the time rigidity and bradykinesia dominate, the disease has entered an advanced stage. Neuronal loss is widespread. Structural atrophy becomes visible on imaging. Functional recovery is no longer possible. What began as subtle restlessness has become motor disintegration. Movement persists, but control does not. As Huntington's disease progresses beyond isolated motor instability, the most disruptive losses occur in systems that regulate behavior, judgment, and emotional restraint. These changes are often mistaken for psychological decline, yet their origin is anatomical and circuit-based. The collapse begins in Fronto-Striatal networks. These networks link the prefrontal cortex to the striatum, allowing cognitive goals, social norms, and long-term consequences to regulate behavior in real time. They suppress impulsive actions, delay gratification, and modulate emotional responses. When these circuits function, thought precedes action. In Huntington's disease, this regulation erodes. Medium spiny neuron loss disrupts inhibitory output from the striatum to downstream nuclei. The prefrontal cortex continues to generate plans, evaluations, and intentions, but its influence over behavior weakens. Signals that should be filtered are released. Thoughts translate into actions without sufficient restraint. This produces a characteristic pattern of executive failure. The patient can still reason. They can explain consequences. They understand social rules. What fails is the ability to consistently apply that understanding under real-world conditions. Impulsive remarks escape control. Risky decisions are made despite awareness. Emotional reactions occur without modulation. This is not ignorance, it is disinhibition. Irritability increases early. Minor frustrations provoke disproportionate anger. Emotional responses feel sudden and difficult to suppress. Family members describe personality change, often interpreting it as moral or psychological decline. In reality, inhibitory circuits are failing. Judgment becomes unreliable. The patient may recognize inappropriate behavior after it occurs, but cannot prevent it beforehand. This post hoc awareness is a defining feature of Huntington's disease and a major source of distress. Insight is often preserved early. The individual knows something is wrong. They recognize changes in behavior and impulse control. They may feel shame, frustration, or fear in response. This preserved insight distinguishes early Huntington's disease from primary psychotic disorders and many dementias. However, insight does not restore control. As disease progresses, executive dysfunction deepens. Planning becomes impaired. Multi-step tasks are difficult to initiate and sustain. Decision-making slows or becomes erratic. The ability to shift strategies deteriorates. These changes reflect loss of coordinated fronto-striatal signaling rather than loss of intelligence. Attention becomes inconsistent. Focus can be maintained briefly but collapses under complexity or distraction. The patient may appear careless or unmotivated. In reality, the neural infrastructure required for sustained executive control is disintegrating. Psychiatric symptoms often dominate clinical presentation during this phase. Depression is common, but it does not explain the pattern of deficits. Anxiety may appear, often driven by awareness of declining control. Obsessive or compulsive behaviors can emerge as inhibitory balance fails. In some cases, apathy replaces irritability as motivational circuits collapse. These symptoms fluctuate early, reinforcing psychiatric misclassification. Medications may blunt affect or worsen motor symptoms without addressing the underlying disease. Psychosis can occur but is not the defining feature. When present, it typically emerges later and reflects widespread circuit disruption rather than primary psychiatric pathology. Hallucinations and delusions are not the rule. Loss of restraint is. Language remains largely intact throughout this stage. Vocabulary, grammar, and comprehension are preserved. Speech content remains meaningful, even as speech production may be disrupted by motor instability. This preservation of language further distances Huntington's disease from cortical dementias. Memory storage is also relatively preserved early. The patient can recall events and recognize people. What fails is working memory deployment and executive organization. Information is available, but poorly managed. This dissociation confuses diagnosis. Clinicians expect neurodegeneration to erode memory first. Huntington's disease violates that expectation. It dismantles control systems before storage systems. The brain knows, but it cannot regulate. As Fronto-Striatal collapse advances, social functioning deteriorates. Inappropriate comments, impulsive actions, and emotional volatility strain relationships. Employment becomes difficult to sustain. The patient may lose work not because of incompetence, but because of unreliability and behavioral disruption. Legal and financial consequences may follow. Risk assessment fails. Impulse overrides foresight. These outcomes are often attributed to poor judgment rather than neurological disease. Over time, insight itself begins to erode. As cortical involvement increases and white matter connectivity declines, self-monitoring weakens. The patient becomes less aware of deficits. Behavioral changes become less distressing internally but more disruptive externally. This transition marks a shift from frustration to apathy. The loss of insight does not restore peace. It removes the capacity to recognize danger. At this stage, supervision becomes necessary. Not because the patient lacks intelligence, but because the circuits that translate understanding into safe behavior are gone. The executive and psychiatric collapse of Huntington's disease is therefore not a failure of mind. It is a failure of restraint. The disease dismantles the neural systems that suppress inappropriate movement, behavior, and emotion. Thought persists. Awareness may persist. Control does not. This is why Huntington's disease is so often misinterpreted. The patient appears capable in conversation, yet fails catastrophically in action. The discrepancy is not willful, it is structural. By the time executive collapse is fully established, the disease has already progressed beyond early intervention. Neuronal loss within fronto-striatal circuits is underway. The window for preserving autonomy is closing. What remains is a nervous system that can still think, but no longer reliably govern itself. The final acceleration of Huntington's disease is driven not by movement alone, but by collapse of the neuron's ability to survive. Long before widespread cell death becomes visible on imaging, neurons enter a state of metabolic crisis from which recovery is no longer possible. This crisis is not sudden, it is cumulative. Neurons affected by mutant Huntingtin exist for years under increasing metabolic strain. The protein disrupts transcription, clogs clearance systems, and destabilizes synaptic signaling. These changes are survivable only as long as the cell can generate sufficient energy and maintain internal balance. Eventually, it cannot. Mitochondrial dysfunction is central to this failure. Mutant Huntingtin interferes with mitochondrial biogenesis, transport, and enzymatic activity. Mitochondria become fewer, less efficient, and poorly distributed along axons. ATP production declines. Neurons attempt to compensate by increasing glycolysis, but this pathway cannot meet the energetic demands of sustained synaptic activity. Energy failure emerges first during stress. Complex movement, emotional arousal, and cognitive load increase ATP demand. Neurons operating near their metabolic limit begin to fail under these conditions. Synaptic transmission becomes unreliable. Action potential propagation weakens. Calcium buffering collapses. Calcium dysregulation marks a critical escalation. Excess calcium enters neurons through overactive glutamate receptors and impaired ion regulation. Elevated intracellular calcium activates destructive enzymes, calpains, phospholipases, and endonucleases that degrade cytoskeletal proteins, membranes, and DNA. This is not programmed death yet. It is uncontrolled injury. At the same time, oxidative stress increases. Impaired mitochondria generate reactive oxygen species that damage lipids and proteins. Antioxidant defenses are insufficient. Damage accumulates faster than repair. Axonal transport failure compounds the crisis. Neurons depend on long-distance transport of proteins, vesicles, and mitochondria. Mutant Huntingtin interferes with motor proteins and microtubule stability. Distal axons and synapses are deprived of resources. Synaptic terminals retract. Connectivity erodes. This loss of connectivity precedes cell death. Neurons may remain alive but disconnected, unable to participate in functional circuits. This contributes to cognitive and motor decline even before neurons die. Network failure accelerates as surviving neurons become isolated. Transcriptional dysregulation deepens the damage. Mutant Huntingtin suppresses genes involved in neuronal maintenance, synaptic plasticity, and stress response. Protective proteins decline. Repair pathways weaken. The neuron loses the ability to respond adaptively to injury. Over time, these pressures converge. Energy depletion, calcium overload, oxidative damage, and loss of trophic support push neurons past a survivable threshold. Apoptotic pathways activate. Caspases cleave cellular components. The cell commits to death. Neuronal death in Huntington's disease is selective, but progressive. Medium spiny neurons die first. Cortical neurons follow later. White matter tracts degenerate secondary to loss of neuronal bodies and axonal projections. The disease spreads from focal subcortical loss to distributed network collapse. Glial cells respond to neuronal death by proliferating. Astrocytes form scar tissue. Microglia clear debris. This response stabilizes damaged regions structurally, but eliminates the possibility of functional recovery. Scar tissue does not conduct signals. Once this stage is reached, reversibility ends. No therapy can resurrect dead neurons. No intervention can reassemble lost circuits. Treatments can slow progression or reduce symptoms, but they cannot restore what has been destroyed. This is the biological limit of Huntington's disease. The progression from metabolic dysfunction to cell death explains the clinical trajectory. Early symptoms fluctuate. Later symptoms stabilize. Variability gives way to permanence. Good days disappear. Patients experience this shift directly. Effort no longer improves performance. Concentration does not suppress movement. Structure does not restore behavior. The nervous system no longer has reserve. This transition is the point of no return, even before widespread atrophy is visible on imaging. By the time structural loss is obvious, the cascade has been active for years. Huntington's disease is therefore not defined by the moment neurons die. It is defined by the moment they lose the capacity to survive. This loss unfolds silently, beneath preserved awareness and intact intelligence. The mind remains present as the cellular machinery that sustains it collapses. The fear in Huntington's disease is not fear of sudden catastrophe. It is fear of inevitability, of watching capacity drain away while understanding remains. Once metabolic failure dominates, the disease no longer behaves as a slow imbalance. It becomes a degenerative cascade, driven by physics and chemistry rather than chance. From this point forward, the nervous system is not failing intermittently. It is failing permanently. Huntington's disease reaches its point of no return, not when the first neurons die, but when the brain can no longer function as an integrated network. This transition marks the collapse of compensation and the onset of irreversible decline. Early in the disease, neuronal loss is focal. The striatum bears the greatest burden. Cortical regions remain structurally intact. White matter pathways still transmit signals, though with increasing inefficiency. The nervous system adapts, redistributing workload across surviving circuits. This adaptation has limits. As medium spiny neurons are lost, the basal ganglia no longer regulate cortical output effectively. Motor commands escape inhibition. Behavioral restraint fails. Yet the cortex still possesses the capacity to generate thought and intention. The system is imbalanced, not destroyed. The point of no return is crossed when degeneration extends beyond the striatum into the networks that connect the brain as a whole. Cortical involvement accelerates. Frontal and parietal cortices begin to lose neurons due to prolonged metabolic stress, disrupted trophic signaling, and impaired connectivity. Executive dysfunction deepens. Planning, abstraction, and judgment degrade further. Insight weakens. The patient becomes less aware of deficits and less able to anticipate consequences. White matter degeneration follows neuronal loss. Axons projecting from degenerating neurons retract and fragment. Long association fibers lose integrity. Communication between distant cortical regions slows and fails. The brain's ability to synchronize activity across networks collapses. This disconnection is decisive. Cognition depends not only on individual neurons, but on the timing and integration of signals across regions. When white matter tracts degenerate, information processing becomes fragmented. Tasks that require coordination across domains, motor, cognitive, emotional, become impossible. At this stage, compensation fails entirely. No region can assume the role of another because the connections required for substitution are gone. Neural plasticity cannot overcome the absence of pathways. The nervous system is no longer adaptable. Motor function deteriorates further. Hyperkinesia gives way to rigidity and bradykinesia. Voluntary movement becomes slow and effortful. Postural instability worsens. Swallowing and speech are severely impaired. These changes reflect both cortical and subcortical failure. Cognitive decline becomes global. Memory retrieval weakens. Attention collapses. Language output diminishes. The patient may still understand simple commands, but complex processing is lost. The disease now resembles a dementia, though its origin is subcortical and network-based, rather than cortical first. Behavioral regulation is absent. Impulse control is gone. Emotional responses are blunted or inappropriate. Social engagement deteriorates. Apathy often replaces irritability as motivational systems collapse. The personality changes are profound, not because identity is erased, but because the neural systems that express it are destroyed. This stage is marked by dependence. Independent living is no longer possible. Supervision becomes continuous. Basic activities require assistance. Feeding, mobility, and communication are compromised. The nervous system has lost the capacity to sustain autonomous function. Imaging at this stage reveals widespread atrophy. The striatum is severely shrunken. Cortical thinning is evident. Ventricles are enlarged due to loss of surrounding tissue. White matter volume is reduced. These findings confirm a process that has been active for years. Treatment at this stage is palliative. No intervention can reverse network collapse. Symptomatic treatments may reduce distress or manage complications, but they do not alter trajectory. The disease has crossed from progressive to terminal in character. The point of no return in Huntington's disease is therefore not a single event. It is the cumulative loss of connectivity, integration, and adaptability. Once reached, the brain can no longer function as a coordinated whole. The tragedy of Huntington's disease lies in the clarity of this endpoint. The gene determines the process. The protein drives the damage. The networks collapse in a predictable sequence. The individual remains alive, but the systems that supported movement, behavior, and cognition are gone. This is not sudden death. It is structural disintegration. And once it occurs, no therapy can reconstruct the brain that was lost. After Huntington's disease crosses the threshold of network collapse, the disease enters a stable aftermath. Progression may continue in degree, but not in kind. The systems that once coordinated movement, behavior, and cognition have been structurally dismantled. At this stage, treatment goals are limited and clearly defined. There is no disease-modifying therapy that halts or reverses Huntington's disease. Symptomatic treatments may reduce chorea, manage rigidity, or dampen psychiatric distress, but they do not alter the underlying neurodegenerative process. The expanded Huntingtin gene remains active. Mutant protein continues to be produced. Neuronal loss does not reverse. This distinction matters. Medications that suppress movement do not restore control. Antipsychotics and dopamine-modulating agents may reduce visible motor excess. but they often worsen rigidity and cognitive slowing. The nervous system trades one failure mode for another because the circuitry itself is gone. Supportive care becomes the focus. Physical therapy aims to preserve mobility and prevent contractures. Occupational support adapts environments to compensate for lost coordination and executive control. Speech and swallowing therapy reduce aspiration risk and maintain communication for as long as possible. These interventions preserve safety and dignity. They do not restore independence. Cognitive decline stabilizes into a chronic state. Memory, language, and recognition may persist in fragmented form, but integration is lost. Awareness often fades. The individual becomes less able to recognize losses or anticipate consequences. Identity erodes not because memories disappear, but because the neural systems that express personality and intent no longer function. Dependence becomes total. Feeding, mobility, and personal care require assistance. Complications such as aspiration pneumonia, malnutrition, and infection become major causes of morbidity. The disease no longer unfolds quietly. It becomes physically consuming. Genetic finality defines the aftermath. Unlike many neurodegenerative diseases, Huntington's disease is not stochastic. It is encoded. The mutation does not arise spontaneously later in life. It is present from birth. Every affected individual follows the same biological logic, even if the timeline varies. This certainty shapes family impact. Children of affected individuals face a 50% risk of inheriting the mutation. Genetic testing offers knowledge without remedy. Family planning, psychological burden, and ethical dilemmas extend the disease beyond the individual. Huntington's disease is not confined to one nervous system. It propagates across generations. The stable aftermath is therefore not only neurological, it is existential. Yet from a biological perspective, the disease is straightforward. Expanded CAG repeats produce mutant Huntingtin protein. The protein disrupts transcription, metabolism, and transport. Medium spiny neurons die. Circuits collapse. Networks fail. There is no mystery left at the end. What remains is the limit of intervention. Research continues. Gene silencing strategies, antisense oligonucleotides, and protein-lowering approaches aim to reduce mutant Huntingtin expression. These approaches target the source rather than symptoms. However, once neuronal loss is advanced, even perfect suppression cannot restore what has been destroyed. Timing remains everything. The stable aftermath of Huntington's disease is therefore not failure of medicine. It is the consequence of irreversible biology. Some systems once lost cannot be rebuilt. The fear embedded in Huntington's disease is not fear of uncertainty. It is fear of inevitability. From the moment the gene is inherited, the trajectory is set. The disease unfolds slowly, dismantling control before memory, restraint before understanding. Awareness often persists long enough to witness decline. This is pathology of fear, and this fear is real.